and I want to make sure our speakers have enough time because I'm really looking forward to hearing what they have to say. So welcome, this is session 1B, which is the community antimicrobial prescribing session. My name is Kirsty Buising. I'm the Deputy Director of NCAS, who's one of the partner host organisations for the forum. And I'm delighted to introduce our first speaker this morning, who is Professor Danielle Mazza. So Danielle is the Head of Department of General Practice at Monash University here in Melbourne. She's a Chief Investigator on the NH&MRC Centre for Research Excellence, which constitutes the National Centre for Antimicrobial Stewardship, and she's heading up the General Practice stream. Her major interest is in translational research in primary care, and she has a particular focus on closing evidence practice gaps in women's sexual and reproductive health, preventative care, antimicrobial stewardship, and the primary care aspects of cancer management. So would you join me in welcoming Danielle? Thank you.
Hi everyone, you've made it to the most important session of the whole forum. And I'd just like to get an indication before we start as to how many of you actually work in general practice or primary care. Would you put up your hand if that's the case? Okay, so for many of you, it'll be a little bit of an introduction to the space. And what I'd like to do is give you the context of what the typical consultation is like that we deal with antibiotic use in general practice, talk about current prescribing patterns, look at all the various perspectives that we need to address in general practice in antimicrobial stewardship, and then talk a little bit about what the college is doing and what I think needs to be done. So Evie was my patient this week, actually. My first patient, 8:30 Monday morning, I did a session, and she came in, she was looking a bit pale and tired, and it was 8:30, she came in with her dad, and I hadn't actually met either of them before. And Dad says to me, Evie's been coughing for the last few days, and she started last week with a bit of a runny nose, but it's gone to her chest. That's the code word, it's gone to the chest. And her cough is so bad that she can't sleep at night. And not only can she not sleep, but she's keeping the whole family awake. And he volunteered that her brother had had the same cough last week. And we brought him in to see Dr. X, who works in the room next door to me, and that made me a bit concerned because Dr. X has a little bit of a reputation in our practice. He sees a lot of children and tends to prescribe a lot of antibiotics, and Dr. X gave the family a script for the brother, and the cough stopped straight away. And we're going away this weekend, and we need to get this sorted before we go. So how's that for pressure? But just hand over the script and let us get out of there. That's what I felt anyway. I felt pressure. I felt pressure because I didn't know this family, so they didn't know me and my prescribing patterns. And I didn't know this little girl and her medical history. I didn't know the father, and I had the pressure of my colleagues' practice. So what did I do? I took a good history and examination, and Evie had no history of asthma or anything else that I should be concerned about. She was in her school uniform, which made me think that her dad was going to send her off to school anyway, so she couldn't be that sick. She started coughing during the consultation, and I would have been annoyed if my child was coughing like that too, I must admit, because one of those troublesome coughs that I could see was irritating her. She was afebrile, had a completely clear chest, her throat was a bit red, ears were normal, small cervical glands, usual scenario. So what did I do? I flicked open her brother's file, and I saw indeed that he had had some Moxil last week, and I started on my usual spiel And I explained to Dad that Evie likely has a viral upper respiratory tract infection, and I highlighted all the factors that I hoped would convince him to accept my approach, which was that she had no temperature, her chest was clear, I anticipated that her symptoms would improve over the next few days, antibiotics don't treat viral infections, and that we would only be promoting resistance if we prescribed. But what did he do? He pushed back. But the antibiotics worked on her brother. We're going away for the weekend and it'll be difficult to see anybody if we need to, and listen to that cough. Poor kid can't sleep and neither can we. So I tried. And this is the scenario that happens every day, multiple times a day. So what are my options at this point? I can stand my ground and refuse to provide a prescription. I can ask Dad which antibiotic he prefers. I can provide a delayed prescription, or I can shut up shop and just go home. It's all getting. And in the end, I gave him a delayed prescription, which is what I tend to do in these situations, with the advice that it's not reasonable to fill it now, she's going to get better, but if by chance you feel she's getting worse, then you might decide to fill it in. And that's kind of a strategy that we often use in these kinds of scenarios. So I hope that gives you the context of what we're dealing with in general practice. It's not like you're in a hospital, and in hospitals patients get told what to do and told what their management is, hopefully in a more patient-centred way than that sounds. But in general practice, it is very much a two-way dialogue, and consultations are interactions with your patient where there is shared decision-making going on. I've been very fortunate to have three wonderful PhD students work with me in this area. Ruby Buising, who's just submitted her PhD and who's been focused on the knowledge, attitudes and practice of parents and primary care providers in prevention and management of respiratory tract infections in young children. Leslie, who's about midway through, who's focused on identifying a framework for antimicrobial stewardship in general practice, and Sajal, a young man from Bangladesh, a pharmacist who's investigating the role of pharmacists in improving antibiotic stewardship. And I'm going to highlight some of their findings in my presentation today. So Leslie has just had a paper published this week in the Australian Journal of General Practice. Congratulations. And it looked at current prescribing patterns in general practice of antibiotics, because it's quite difficult to get hold of accurate information. And I'll go into that a little bit later on. But what Leslie did was that she analysed the electronic medical records from 50 general practices around Melbourne's inner east, and she extracted data about their consultations and antibiotic prescriptions from 2010 to 2014. And I think Leslie's findings kind of reinforce what we've been suspecting, which is that young children in general practice receive antibiotics at a higher rate per consultation than either very young infants or adults. That we are getting a slow but gradual decline in the rate of antibiotic prescribing per consultation, with the largest declines occurring in those young children. But in older people aged over 50, there's little variation in antibiotic prescribing rates over time. And importantly, for antimicrobial stewardship in general practice, very few prescriptions have an associated label of the reason for that prescription. So if we're going to be doing work in antimicrobial stewardship in general practice, we need to understand why GPs are prescribing antibiotics and for what diagnoses and to audit that against guideline recommendations. And this is going to be difficult. Let me turn now to Ruby and some of the work that she's done. I feel like they should come up and give these presentations. Ruby's published a paper looking at practitioner perspectives, which are important. And she interviewed 30 primary care providers and explored their knowledge, views and management of respiratory tract infections, and also how they symptom managed and what they recommended about over-the-counter medications. And she found, much like I described in my consultation that I had earlier this week, that issues like time constraints and parental anxiety and general practitioners' perceptions of what parents want, fear of losing patients, which is probably unique to the Australian scenario where we don't have patient registration practices, are very important factors. That there's conflicting advice about over-the-counter medications and how to manage children in terms of resuming normal activities. And she very accurately described the complex interactions which were emotional and psychological factors that influence decision-making of primary care providers in these scenarios. Interestingly, Ruby then went on to do some work with parents, and she did some focus groups and surveys of parents and carers of children, and interestingly found these dissonant views. So the GPs thinking that parents are wanting antibiotics and putting pressure, and that they'd go somewhere else if they didn't get what they wanted. But the parents actually saying, no, well, they have good knowledge of respiratory tract infections and appropriate antibiotic use. And their main expectation was around GPs providing a diagnosis and discussing management and receiving reassurance that their child is not seriously ill. And that their satisfaction is not dependent on receiving antibiotics. So we've got some work to do there about GPs feeling confident that they shouldn't succumb to, or shouldn't feel that they are being pressured, that they really need to be addressing the parental concerns, which is about the well-being of the child. I'd like to go on now to talk about some of the system issues. We've talked about the provider aspects, parental aspects, patient aspects, and now some of the systems issues. And Brendan talked about this morning in his presentation, where the government's giving a lot of focus at the moment to doing things like trying to take away the automated repeat prescribing. You can see this example here, where there's an automatic repeat that pops up when you order some Keflex. But these mechanical issues in prescribing are really important if we're going to address antimicrobial stewardship in the general practice setting. Things like the not having a compulsory field to record the clinical indication, the automatic repeats, but also the quantities of the antibiotics that are prescribed. And a common one I always get frustrated about is the prescription of penicillin. I want to prescribe 20, and when I click the button, 50 comes up. I don't want to give them 50, I want to give them 20. So I actually have to manually go into the system and change that. And you'll know that when you have had antibiotics in the past, that you've often received more than you actually required. So that brings us to the role of pharmacists. And we're not fortunate in general practice. We don't work in a hospital environment where we have access to our colleagues in pharmacy and in other disciplines, ID physicians on hand. We work in small businesses, very isolated. We often don't talk to anybody except our patients and our practice manager and our receptionist when we go in to work for the day. But we've got pharmacists down the road. And it's really important to think how we might work collaboratively with pharmacy. Sajal's doing some work in this area, and it's certainly a government priority in primary care to try and involve pharmacists more in their work with general practice. There's been the introduction of things like home medicine reviews, but in the area of antimicrobial stewardship, there hasn't been much initiative, and there's lots of potential here. And Sajal hopefully will be publishing his systematic review very soon. He's submitted it for publication, presenting it at the MAPCRAD meeting next week, where he looked at the effectiveness of interventions involving pharmacists on antibiotic prescribing by GPs and found that these kinds of interventions can achieve a decrease and an increase in guideline adherence. So I think this is certainly an area we can work more in. I talked about the lack of accurate data to inform AMS programs in general practice. Our PBS is not sufficient. It contains no clinical information. The Medicine Insight program, which is run by the NPS, is a voluntary program, which is not Australia-wide at the moment. Our Beach survey, which gave us a lot of data about what happens in general practice, is no longer funded by the government, which is a great shame. And we don't have an agreement on who's supposed to gather the data, who's supposed to audit it, report on it, who has responsibility. And GPs are often not very keen to actually give up their data in the first place. They're very concerned and confused about privacy issues. You will have seen in the My Record debate. So the college, as the peak professional body in general practice, has responded to the issue of antimicrobial stewardship last year with a position statement. And I think leadership in this area is very important. And the college is wanting to provide that leadership. And I think has come out with some very pertinent statements. The first one, that there should be a collaborative multi-sectorial approach. And that's certainly what NCAS is all about promoting. But secondly, and I think importantly, to recognise that patient safety is a real concern for GPs. And while there might be a wish to decrease antibiotic use and to minimise resistance, there is always going to be concern about issues to do with regional variation and the primacy of the patient in front of you and your need to act in their best interests and not compromise patient safety. And also a recognition that tailored approaches are necessary because we don't have the infrastructure and the capacity that hospitals provide. So they've issued a response to antimicrobial resistance, and I'm just going to very quickly shoot through these because I've spoken too much. The focus is on community education, clinical governance, GP education and providing educational resources for GPs to use, collaborating with the NPS and supporting implementation of guidelines through integration in software, things like that, focusing on infection control. Very importantly, this issue of outcome monitoring needs to be addressed in general practice. We don't have adequate outcomes to audit against. We need to develop appropriate antibiotic usage indicators for use within general practice, and we need to come to some kind of determination about who's doing the monitoring. Is it national, state? Is it at the level of the primary health networks? How are we going to do that? And importantly, we need to fund general practice, and I'm talking to the policymakers in the audience now. We need to fund general practice research in this area. The MRFF calls have been a little bit oblique in the way that general practice can engage in this area through research funding, and we have lots of questions that need answering. So what I think is needed is a framework for antimicrobial stewardship in general practice that pulls together all of these elements: practitioner, patient and system change. And it needs to be agreed upon and worked towards with all the key stakeholders. The College of GPs is a good start, but there are lots of other stakeholders in the primary care space that have an impact on this issue. ACRM, the Primary Health Networks, the Digital Health Agency, PBS, software vendors, pharmacies, society, pharmaceutical companies and GP training organisations. And hopefully we'll be able to make a difference. Thank you.
Danielle, that was terrific. I'm going to invite our next speaker up, and maybe if there's time at the end, we might save some questions for them, if that's okay, because I think we're very keen to give our two speakers plenty of time to tell us about what they've prepared. So I'm inviting Professor Mieke van Driel to speak. She's the head of the primary care clinical unit and head of the discipline of general practice in the Faculty of Medicine at the University of Queensland. She practices as a general practitioner in the Aboriginal Medical Service. Her main interests are in translating evidence into practice with a special focus on vulnerable populations and global health. And her work in antimicrobial stewardship in primary care has contributed to a better understanding of the drivers of antibiotic use in the community. So thank you, Mieke.
Thanks, Kirsty. And thank you for inviting me. My brief was to put an international perspective onto the discussion we're having. And coming from Europe, having come from Europe about 11 years ago now, and having been part of the European movement, if I can say so, in bringing antibiotic use and antimicrobial stewardship to the forefront in general practice and in community practice. I would like to acknowledge the work that my colleagues there have done. I have been part of a group that's called GRIN, which used to stand for General Practice and Respiratory Infections Network, but has recently been rebranded as a General Practice Research in Infections Network, as we have ventured into other than respiratory infections, as you know, it obviously is very important to look at all infections. And so some of the work I'll be talking about now is drawn from that group of excellent researchers. When we talk about international, I have to, what became very clear to me that that's all about perspective, and the perspective is where you stand. And I guess having come from the bottom right corner there, where I was in Belgium before I came to Australia, that's a very different perspective of the world than being in Australia. So if you look at our world here, then what has happened down there in the bottom right corner really matters. So when I use this slide also to convince my colleagues in Europe that what happens in Australia does really matter. Just to set the scene, what's the situation here? And these are some data of the fantastic AURA report that we can now draw upon, and others. That we are really, really enthusiastic users of antibiotics. And it comes down to almost 1 in every 2 Australians gets a script for an antibiotic each year. And that our use is increasing instead of going down. And in terms of general practitioner use, it's been calculated that for a full-time general practitioner, they would write a script for an antibiotic every working day, which is quite grim if you look at it that way. My colleagues at Bond University have calculated that we probably use antibiotics at 4 to 9 times the rates that are recommended in our excellent therapeutic guidelines, as has been referred to already. Danielle's also shown us a little bit about the data that we have. We know that most of antibiotics are used in the community, so it's really time to hone in on that, and most of those antibiotics are prescribed by general practitioners. then of course it's important to know what they use them for. And we do have problems in identifying the indications for antibiotics. But fortunately, we do have a number of databases that we can draw upon. And I'd like to point out to you one that hasn't been mentioned yet, but is a fantastic source of data that we have from general practitioners, general practice registrars, so GPs in training, which is the recent study that I have the privilege of being part of. And it is kind of a beach type registration where our GP registrars record 60 consecutive consultations at 3 different time points during the training, which has given us a wealth of information about what they're seeing, what they're doing, and also how we can influence that. And we have about 300,000 consultations in our database since its inception about 10 years ago. So what we see here is that a lot of antibiotics are used for lower respiratory tract infections, and a lot more than our guidelines really recommend. However, what is also clear, if you know that all the 2 other databases are basically established general practitioners, that our GP registrars are actually doing slightly better. And that's good news. So what we need to do is make sure that they continue that and don't regress towards the mean and take up all the bad habits of their supervisors and teachers. Okay, back to where do we fit in the international picture? And I've gratefully taken these data from the AURA report, which shows Australia in the international context in terms of antibiotic use. The Netherlands is down here, and Sweden are 2 of the lowest prescribing countries in Europe, and Australia has almost twice the volume of prescriptions. There is some good news, because we really need to also celebrate what we do very, very well, and that is in terms of resistance to fluoroquinolones. In Australia, as you may or may not know, we've restricted use of that, and we've been extremely successful in limiting the development of resistance. So here's some messages to the world that we can send from Australia. So there's a lot of where do we start to address these issues? Where do we start to improve our prescribing in the community? And as a prescriber myself, Danielle's story is very, very familiar, and it's sometimes really hard to stick to the guidelines, as you know. But where to intervene? So there's lots of this diagram shows that it is a complex area, which starts with the patient, which then involves the doctor-patient encounter and everything that happens after that, and all the stakeholders involved. So I'd like to take you on a little bit of a journey over the past 20 years, where we've gained some inspiration from studies overseas. And it starts for me in the early 2000s when a colleague, an anthropologist in Belgium, who was also at Ghent University, where I was at the moment, and who did a very simple and very creative study. He asked people on 2 sides of the border where they speak the same language, Dutch or Flemish, and I'm married to a Belgian. I'm Dutch, and my husband is Flemish, and if I tell him that they're the same language, he'll disagree, but he's not here now. So speak the same language, and he asked people on both sides of the border, and gave them scenarios, but also asked them to keep a diary of their infection throughout a winter season. And they interviewed them, and guess what they found? That people in Belgium were more likely to label their symptoms of cough and lower respiratory or upper respiratory tract infections or lower respiratory tract infections as bronchitis. They were less likely to self-medicate, and they used more antibiotics. And that is also reflected in what we know about the volume of use in Belgium versus the Netherlands. Belgium being a quite high prescriber, and the Netherlands being a bit on the stingy side. So they then have said that these cultural issues and they hypothesized that it had something to do with Belgium being Catholic and the Netherlands being predominantly Protestant. But I mean, those are hypotheses. But I think really interesting lessons that culture really matters, even in populations that are very closely located. So we've had a lot of awareness campaigns, and I've just pulled out a few, and maybe I'm digging too deep, but I thought it was nice to look at different cultural approaches. And if we start with the Australian campaign of a couple of years ago, where we use our media figures to talk to the audience and to get their buy-in. So Australians like to look at their media icons. The one in the middle is from the UK. Do people in the UK need more explanations to get a message across? The strip book, the comic strip book down in the bottom, is from Belgium. The Belgians love their comics, and this is a way of speaking to the Belgians that is very natural, and is maybe the best way to get that. And the top one on the left is from the United States, and I don't want to make any comments on that one. So that's the part where we inform the audience. Now, about 20 years ago, in that green group, there was a very strong acknowledgement of the fact that we still needed evidence in primary care. And that inspired a beautiful project that was funded by the European Union called GRACE. And GRACE was the vision of a Belgian microbiologist, Herman Goossens, and his work has been cited already this morning. And GRACE was a study that involved a huge number of disciplines and about 13 European countries, and looked specifically at lower respiratory tract infections. We knew there's a lot of prescribing for lower respiratory tract infections. There was evidence that probably antibiotics are not as useful as we think, but most of the data was not from primary care, and there was a real need to look into that and also see how we can expand that. Now, one picture is not showing up, but the one on the left was the picture of the 13 European countries that were participating in the GRACE study. Overall, a population of over 400 million people, and if you would transpose that group of nations into Australia, it would only be part of Australia. And we, of course, have a very, very small population. So the data collected is really from a really large, oh, here it is, sorry. It's from a large population. Just to give you a few snippets of what GRACE showed us, GRACE had a component of observational studies that for the first time looked at in a population, does it really matter to give antibiotics to someone with a cough? And these Kaplan-Meier graphs or survival graphs show how people fared if they got an antibiotic, which is the top, did not get an antibiotic, which is the top left-hand corner, and if they got one of the other antibiotics. And what it basically shows that getting an antibiotic or not, and which antibiotic was given, does not really impact on the resolution of symptoms, or how soon people got better. They all got better. And there's some slight differences, but they were, overall, it doesn't really matter. So this was the first time in an observational cohort to show that it's safe to not prescribe antibiotics, and it doesn't really make much difference. Another really nice study I thought was and I use this clinical message in my discussions with patients, is that we all think that the sputum color really matters, and we're kind of obsessed with this. We ask our patients, "Oh, do you have sputum?" And so If yes, what color is the sputum? And people go into great detail to describe the color of the sputum. Well, you can just safely ignore that information because it doesn't really matter in this study. And it's very likely that in people who have asthma or COPD, you know, and other comorbidities, it's a different story. But these are people with uncomplicated cough and sputum, and so color of the sputum doesn't really make an impact on if people get better or not. So the next step was we had some of this data about the clinical environment and clinical information. The next was to look at, all right, how can we help GPs make better decisions in the consultation room? How can we help them convince their patients often that they don't need an antibiotic? And one of the most obvious things to do is, of course, provide information, make handouts, and hand them out to the patient, and use that as a negotiation tool. And my colleague Mieke Francis from in Cardiff in Wales did a very nice study, just handing out information booklets to patients of children, and that reduced the antibiotic prescribing rate in that setting with similar parental satisfaction. The next step was a study from a colleague from the Netherlands who looked at the use of CRP testing as a point of care test to show patients that their infection was most likely not bacterial, and that can be used as an argument to avoid using antibiotics. Again, they found that using that for people with cough, that reduced significantly the amount of antibiotics prescribed, with no impact on patient recovery nor satisfaction of care. And that finding was more recently confirmed in a Cochrane review, where 6 studies were pulled together and showed the same thing. So these were little elements, and the team in Cardiff then said, all right, well, we're going to put some of this all together and see if we could get some effect by pooling it all, if we can get a better effect. And they designed an intervention which was an audit, so giving people feedback on their own prescribing, an online module, and also face-to-face. A reasonably low intensity, but nevertheless a face-to-face component to it. And they saw a reduction in antibiotic prescriptions. Not as much as we would have liked, but of course the other studies were very, very much controlled interventions that maybe that helped. Next phase up was, well, the face-to-face is really intensive. Can we do it with less intention? And that is bringing it all into online modules, and that was the intro study. 3 online modules, one about these are the facts. Secondly, this is how you use CRP testing. And thirdly, and probably most importantly, this is how you can communicate with your patients on getting that message across. At baseline, about half the patients doctors who participated in that trial got an antibiotic, and they managed to reduce that amount significantly. Really a small or a low intensity intervention. So we thought, we can do that too. And we don't have to go through in Australia to develop all the other building blocks. We'll just build on what the European colleagues have provided to us. And the CHAPS study was one of the first in Australia, where we did a similar intro intervention with our GP registrars. We did add a workshop, and because it is easy to get GP registrars together in a room, it's part of their compulsory training program, we had a workshop and we invited one of our ID physician colleagues into that workshop, and that was a very, very effective formula to pass on a message. And we managed to reduce antibiotic prescribing for bronchitis by 15%. Of course, the challenge now is to sustain that, or to keep that, because these GPs will finish the training program and will then go on to being individual prescribers. And following on the success of CHAP, we then replicated that in the GAP study with established GP practices in Brisbane and Gold Coast area, where we also introduced very prominently the delayed prescription. That very small pilot study reduced prescribing as well. Moving on to some other ideas that we have taken from our European colleagues, and one of them is what would be called the social norm feedback, which is what has been mentioned this morning as well by Professor Brendan Murphy, is the feedback to high prescribers. So the CMO, the Chief Medical Officer in the UK, sent letters out, and that resulted in a good reduction in antibiotic scripts, which was actually a really, really cheap one, a cheap intervention. And as you know, we have done something similar and also achieved similar success. And it's great to see that this year's was actually more successful. And it would be interesting to see if that is because of that component of peer comparison, where it's almost like the wall of shame, where you are put right at there as one of the top prescribers compared to what the norm is. And for those of you who are not familiar with one of the great success stories in Europe, Sweden, who I believe has overtaken the Netherlands in their first position of the least prescribing prescribers of antibiotics. What I learned from my Swedish colleagues in the Green is that their success is built on a long commitment, and a commitment at all levels, and also a commitment of government. And that they actually started in the 1990s, early 1990s. So a long time ago. And if we are to get where they are now, I hope we don't need the 20 plus years that they have needed to get there. Other interesting thing is that we always talk about when we come to GRIN meetings is that they use so much penicillin V. And that is very rarely used here. And it seems to work. And I remember when I was in Belgium, it was sometimes impossible to get penicillin V. So just prescribing it was even if you wanted to, was difficult. So it's really interesting to have a look at that. The other thing I learned from them is that they made real good use of the media to support their messages. And they had an ongoing, strong relationship with the media to ensure that the right messages come through. And finally, that it still is to them a top priority. And it was great to hear this morning that antimicrobial stewardship is also top priority in Australia now. And this is just to show how they, when they started the Strama program, they were at a peak, and it's been going down and hasn't gone down much more, but they are already at a very, very low level. So finally, I think there's a lot of room for initiatives in the area of antimicrobial stewardship in general practice. And I'm thinking of not only as general practice or the community as a whole, but really what it comes down to is individual practices. Individual practices have to work out a way to implement judicious use of antimicrobials in their own practice. And the only way of making this happen, I think, is by making it compulsory. It has to be part of what we do. And this Dutch trial, when I thought, oh, no one's probably done this. But actually the Dutch have done this. They've done a trial on making this part of accreditation. And they have found an impact of implementing stewardship in their general practices. And again, the Dutch are already very low prescribers, so 7% decrease doesn't sound like a lot, but if you're already low, that's still good. And it was sustained. So that's something that we need to be looking into, I think, and I'm really looking forward to hearing more about Leslie's work about the frameworks of doing antimicrobial stewardship in general practice. And I recently saw this news message from the BMJ where in the UK they are celebrating their success. And if you read that little paper, there's one message that we might want to think about is that the government in the UK has offered a financial incentive to get GPs to cut down on antibiotic prescribing. Supporting GPs and giving them the means to do the right thing, I think is really important. Thank you.
Very much, Mieke. And I think most of the audience will join with me in saying what a terrific session that was. I think Danielle, some of the challenges and that we're facing with that, Mieke, letting us know about some interventions that have actually that we can, and some that we have applied here in Australia. So in the interest of time, I've realised many of you will need to get to the next session, and so I don't think we have time for questions now, but I'm sure that Danielle and Mieke would welcome them during the lunch break. But join me please in thanking Danielle and Mieke.